Hello, I'm Professor Emily Mercuri, and this is Chapter 19, Central Nervous System Drugs, Analgesics, Sedatives, and Hypnotics, from Essentials of Pharmacology for Health Professions, 9th edition. Chapter Objectives. Upon completion of this chapter, the learner should be able to explain the indications and actions of non-opioid, opioid, and adjuvant analgesics, describe sedatives and hypnotics and their place in sleep, list the side effects of the major analgesics, sedatives, and hypnotics, describe the necessary information for patient education for analgesics, sedatives, and hypnotics, and explain the precautions and contraindications to administration of the central nervous system depressants mentioned in this chapter. Analgesics. You know, I always like to start with what a word actually means, especially when it's a word that may be new to you. So, an is the Latin root for without, and then algian is pain. And so it breaks down to analgesics, meaning without pain. And what analgesics are they are a class of medication that helps to reduce pain. So it's not always going to be possible to take away 100% of the pain, but analgesics reduce pain in a patient. That is their intended effect. The most common reason patients seek medical care is actually pain, believe it or not. And this can be pain anywhere from nerve pain to muscle pain to deep tissue pain. There's lots of different types of pain. And we always want to ask when we are assessing a patient, is this pain acute, meaning is it new, or is it chronic? Have they had it for a long time? Because this might change the way that we choose to treat it. The four most common types of pain include lower back, neck, migraine, and facial or jaw pain. Pain is subjective, meaning it's not a value that you can objectively identify, saying, for instance, somebody vomits, they vomited. That's objective. There's data, there's proof. Pain is subjective because we are relying on what the patient's perception of their pain is. So it's perceived only by the individual. Healthcare professionals assess a patient's pain by asking the patient to describe the pain and its location, and assess the pain severity by using a valid pain assessment scale. There are many different types of pain assessment scales. We're not going to cover all of them in this lecture, but if you look them up, you can find a myriad of them. I'll try to link some into the Canvas page. The most common for adults will be based on a range of 1 to 10. So from 0 being no pain to 10 being the worst pain you've ever felt. What level is your pain now? Or use these symbolic facial expressions to show levels of pain. I think this one's funny because a lot of people will think it's looking at the patient's face. What does the patient look like? But that's not the case. It's more just to give a visual description for someone who may be more visual. And a lot of times we use this also for children who are able to look at a picture and understand that better than a more abstract concept like numbers. So a child from the age of, 6 to maybe 12 might benefit from a FACES scale like this. So you can see down here, 0, no pain, 2, mild pain, 4, moderate pain, 6, severe pain, 8, very severe pain, and 10, worst possible pain. Again, we're not going to go based on the way that the face looks because somebody could be very stoic and they could be in an 8 out of 10 pain and you wouldn't be able to tell on their face versus somebody might be in a 4 and be crying and be more expressive about the pain. So it really ranges based on a person's many different things, their background, their personality, all of that kind of stuff. There are pain scales as well for patients who are nonverbal, but it's not a picture scale like this. It goes on things like, are they grimacing? Are they contracting their muscles? Are they tense? Are their legs kind of rigid and drawn up? Those things all will score points towards how much overall pain that they have. There are 3 main categories of analgesics that we will be talking about today: opioid analgesics, non-opioid analgesics, and adjuvant analgesics. So when we're talking about opioid analgesics, these are going to be typically the most effective at providing pain relief. They are classified as full, partial, or mixed agonists depending on their activity at the receptor. Full agonists are commonly used because their action is like that of opium in altering the perception of pain, and they do not have a ceiling to their analgesic effects. This means there is no plateau to the amount of analgesic relief, and the only limiting factor is side effects from higher doses. Breaking that down, a full agonist is going to be fully covering the receptor to give you that maximal effect. The downside of that is that there are also side effects because it's also with its full saturation on the receptor, it also affects all the downstream processes. So an example would be something like fentanyl. I know many of you have probably heard of fentanyl. It's been in the news a lot as a drug that's commonly abused. We do use it therapeutically as well. But when you have a full agonist like that, it can make somebody go into respiratory depression where they're not taking deep enough breaths or enough breaths. It can make them very drowsy. Someone can easily even stop breathing if they're taking a large amount of a full agonist. And so partial agonists, those are useful in situations where full activation of the receptor is undesirable or could lead to excessive side effects, especially when you're talking about an elderly person, someone who might be more sensitive to medication. And then a mixed, it means it acts as both an agonist and an antagonist. What we'll use oftentimes when we're talking about a mixed opioid is when somebody is withdrawing, it's actually very dangerous for them to quit cold turkey. So cold turkey meaning suddenly, if you're not familiar with that term. So we may use a mixed agonist that will partially be an agonist on that receptor. It will give them a partial effect, but it also is antagonistic to whatever is lingering on the receptor. That's a full agonist. And so it has less side effects. It still gives some of that effect, and we can kind of taper them down more safely. You don't need to go too deep on this one, but I wanted to kind of break those terms down for you because I know they can be confusing. In general, remember that opioid analgesics are typically the most effective at providing pain relief, and they work on the actual pain receptors. Non-opioid analgesics are available over the counter without a prescription. I did not mention it on the last slide, but opioids always require a prescription, and they are very tightly regulated because they have the potential to be abused or misused, and they can also be addictive. So for example, if someone comes into the ER and they have a really bad fracture, let's say, and they require some sort of opioid prescription, we typically only give them 3 days, and they have to follow up with their primary for a continued prescription because we want to make sure we're not giving them something really strong that could possibly cause harm without follow up from a doctor who knows them better than they would, than an ER doctor would know them. But going back to our non-opioids, these are used to relieve mild and moderate pain, fever, and inflammatory conditions. And this group of analgesics is also used as a co-analgesic in severe, acute, or chronic pain requiring opioids. What that means is some medications such as Norco, hydrocodone acetaminophen. So it has a hydrocodone, which is an opioid component, and then it has acetaminophen, which is Tylenol. It has a non-opioid component. So some of our oral medications will be a mix of the two. Adjuvant analgesics are drugs that are intended for the treatment of conditions other than pain, but have shown effectiveness in reducing certain kinds of pain. They also have the ability to enhance the analgesic effects of opioids and non-opioids, produce analgesia alone, or reduce the side effect of analgesics. So an example of an adjuvant analgesic is something like an antidepressant, an anticonvulsant, steroid. So those all work in different ways, but let's break it down. An antidepressant can help modulate pain perception and improve mood, which mood is actually, believe it or not, can be linked to pain or perception of pain. An anticonvulsant blocks some of the nerve signals, and so someone who has a nerve-related pain, that may also help them with pain reduction. And then a corticosteroid, such as prednisone, can help reduce inflammation, and so if the pain is related to inflammation or swelling in an area, that will also help with the pain perception. Also, something like a muscle relaxant, right? You are relaxing those muscles where the pain is. So even though it's not acting on the pain receptor pathway, it is acting as an adjuvant, and it's going to also help relieve pain. Cannabinoids are another one, THC and CBD. They can interact with pain pathways in the brain and spinal cord. And there are a lot of studies kind of researching the therapeutic use of those drugs, specifically THC in cancer patients, because of the effect that can have on the pain receptors. Knowledge check. Which analgesic category is used to treat mild pain and fever? A. Opioid analgesics. B. Non-opioid analgesics. C. Adjuvant analgesics. D. Anti-migraine analgesics. And the answer is non-opioid analgesics. Think of things like Tylenol, ibuprofen, commonly used to treat both pain and fever. Let's do a case study. A 72-year-old patient underwent a total knee replacement. 2 hours after the surgery, the patient's evaluation demonstrated pain at level 9 based on the facial pain scale. Which analgesic would the provider prescribe? Just gonna play devil's advocate here. Typically with a 72-year-old, we are not going to use a facial pain scale. We'll use a 0 to 10 pain scale unless they have some kind of deficit in understanding or cognition. So your choices here are A, non-opioid, B, sedative, C, hypnotic, or D, opioid. Considering we have not gone over sedatives or hypnotics yet, go ahead and throw those out. So you're left with non-opioid and opioid. Typically speaking, we are going to have a doctor's order that says over a certain number on the pain scale, you give this medication, under a certain number, you give this medication. Oftentimes the non-opioids are 5 and under, and the opioids are 5 and over. So in this case, your answer is going to be D, opioid. We do want to exercise extra caution, however, in our elderly population. We want to make sure their pain is controlled, but we also want to be mindful of the time it may take for them to metabolize the medication or clear the medication based on their kidney function and other factors. Sedatives and hypnotics. Sedatives and hypnotics are medications used to promote sedation in smaller doses and promote sleep in larger doses. Sedation, if you're not familiar with the word, refers to somebody being more calm, more sleepy, and there are levels of sedation all the way from light sedation to deep sedation. And deep sedation is something we would use during surgery where somebody is unable to be woken, and obviously that comes with more risk. Versus light sedation, somebody is having a panic attack, we give them a sedative medication and it just calms them a little bit, but they're still awake. So there's a range of doses and a range of different medications we would use. But in general, sedatives and hypnotics, think of them as medications that promote sedation or sleep. Insomnia is actually one of the most prevalent sleep disorders, and chronic insomnia is more prevalent in women and older people. Sedatives and hypnotics depress the REM, rapid eye movement, or dream phase of sleep. So you can imagine that withdrawal after prolonged use can result in a severe rebound effect with nightmares and hallucinations. So oftentimes, if somebody is on these long term, they are not having those dream cycles. However, REM is also a really important time of your sleep cycle to integrate thoughts and memories. So it's important that we're not misusing these medications. Ideally, someone's not going to be on these long term, but we have to weigh a benefit outweighs the risk. So then think about you're on this medication, you're not having these dream cycles, and then suddenly you go off of it. Then all of a sudden your dreams are super vivid. You're having nightmares, you're having hallucinations. That can be very dangerous too, right? Somebody could harm themselves or somebody else while they're having these vivid nightmares. The use of barbiturates for sedation is particularly common for this to happen with these barbiturates. So it's restricted to specific limited circumstances in which the patient can be closely monitored. Barbiturates are also a very big category of meds that get abused, similar to opioids. Benzodiazepines have supplanted barbiturates. So benzodiazepines are what supplanted means is it has kind of taken over as the more primary category of medications that we'll use for sedative hypnotics. They have less potential for abuse, but they are still are high risk and are still highly monitored. It's important to note that withdrawal effects are observed after long-term use, and respiratory depression from these medications can potentially be fatal. Why do they mention that about the long-term use? Is we want people to be aware that if these are needed for a short term, or if this is something that could, again, benefit outweighs the risk, maybe they are very manic, maybe they're having a psychotic episode and what they really need is sleep, this short-term use is not likely to cause any kind of withdrawal or any kind of severe after effects versus somebody who's been using them chronically for a long time. But the respiratory depression, that is the same for opioids and something that we want to be really careful about, especially when we're giving them to older people. We should be prescribing them carefully and monitoring. Some example of benzodiazepines that you might be aware of: Valium, Xanax, Ativan. Those are all really common ones, often prescribed as needed to people with severe panic attacks or other psychiatric disorders. Knowledge check. Chronic insomnia is more prevalent in A, men and young adults, B, women and infants, C, women and older adults, D, men and older adults. The answer is C, women and older adults. The common side effects of major opioid analgesics. The drug here that they give you for the example is tramadol. Tramadol is a partial agonist. In general, these side effects will be similar for all of the opioid analgesics, but remember that a partial agonist is going to have typically less of a significant side effect than a full agonist, such as fentanyl, morphine, Dilaudid, those kind of medications. So side effects: lower seizure threshold. And what that means is in the brain, there is this threshold that has to do with your neurons, with your neurological system for a seizure to occur. Lowering the seizure threshold means it can make it more common or easier for a seizure to occur. Now, this isn't a huge risk for most people, but if there is a history of seizures, that's something we want to be aware of. Sedation, confusion, and dizziness. Hypertension, high blood pressure, and bradycardia, low heart rate. Nausea and vomiting. Constipation. Respiratory depression, meaning it depresses your drive to breathe, so that can be very problematic, as you can imagine. And then physical and or emotional dependence. And then tolerance, which tolerance is different than dependence. Tolerance means that you build up a tolerance to the drug. So essentially, the same dose that was working for you is no longer working because your body's now used to it. So some medications, they will recommend that you take a vacation from, or you take a break from it and then go back on the same dose, because what they don't want to do is just keep building and building and building your dose till you're on a very high dose because of your tolerance. But it's not always something that they can accomplish. If someone's in chronic pain, they may not be able to take a break from that medication. But tolerance is different than dependence. Dependence means that you are relying on it. If you don't take it, you'll start to withdraw. Common side effects of non-opioid analgesics. So there's a few different categories here. Salicylates and other non-steroidal anti-inflammatory drugs, also called NSAIDs. Aspirin is an example of an NSAID. Ibuprofen is an example of an NSAID. So the side effects are prolonged bleeding time and bruising, gastric distress, ulceration, and bleeding, tinnitus, which is ringing in the ears, and hearing loss with overdose, renal insufficiency. So these are processed by the kidneys, so that can lead to issues with the kidneys, and then gastrointestinal or GI symptoms. Because of the potential to cause this prolonged bleeding time, that can cause issues with the stomach, with the gut, and that can make people feel like heartburn or have acid reflux if they are taking large amounts of these medications. Acetaminophen, which is Tylenol. Tylenol has, or acetaminophen has severe liver toxicity. This is at higher risk in higher doses or in patients with previous hepatic impairment. So somebody who has issues with the liver, typically we are not going to prescribe any kind of Tylenol or anything containing Tylenol because it is processed by the liver. Local anesthetics, so something like a lidocaine patch that is just placed onto the area and works only in that area, can cause erythema, which is reddened skin, edema, swelling, and hives, which are welts, that it's kind of like an allergic reaction. And then here it says and allergic reaction. So hives are raised itchy bumps, and then a full-on allergic reaction can occur. Medical marijuana, they are listing it here under non-opioid analgesics. I mentioned it also as an adjuvant. Depends on what you are taking it for. So if you're taking it for pain, it's considered a non-opioid. If you're taking it for other reasons, it may have that adjuvant effect. So it is being taken here medically for pain, considered a non-opioid analgesic. Side effects can include dizziness, feeling tired, increased appetite, and hallucinations. Oftentimes, as I mentioned, it's a great option for somebody with cancer because they may have decreased appetite or be rapidly losing weight. So it can help actually increase the appetite. But then if they're having the side effect of feeling tired or dizziness or those other effects, it may not be worth it for them. It's also important to note that cannabis can cause extreme nausea and something called cyclical vomiting syndrome, where certain people react differently to different strains of marijuana, medical marijuana, and they can have constant nausea, vomiting, and in that case, it's not going to be a good choice for them. Okay, so here are some adjuvants: tricyclic antidepressants, dry mouth, urinary retention, delirium and constipation, sedation, and orthostatic hypotension. What that means is that when someone's changing positions, their blood pressure drops low, especially from laying down to sitting. So we need to make sure folks are educated to get up slowly when they're getting up. Serotonin, norepinephrine reuptake inhibitors, SNRIs. So that's another type of antidepressant typically. It's just in a different category than the tricyclics. These can lead to sleep disturbance, headache, nausea, stomach pain, diarrhea, constipation, dizziness, and sweating. And then anticonvulsants or anti-seizure medications can lead to sedation, dizziness, confusion, hepatitis, rash, nystagmus, and blurred vision. Nystagmus is when the eyes kind of rapidly flicker back and forth. And then weight gains with peripheral edema. Many migraine medications also fall under the category of analgesics, sedatives, and hypnotics. Migraines are the most common neurovascular headache and may include nausea, vomiting, and sensitivity to light or noise. Migraines, and most other forms of headache as well, respond best when treated early. Typically, patients who experience chronic migraines will have something called an aura before the migraine occurs that can help warn them a migraine is about to occur. For some people, that is they start seeing like a halo around lights. They may have a certain smell or a certain kind of color that comes into their peripheral vision. There's many different auras that can occur, but we like to catch them before the migraine gets full blown. I would not wish these on my worst enemy. My mom had migraines growing up and would be completely incapacitated in her room, vomiting with all the lights off, very sensitive to any light or sound. So migraines are a pretty big deal and they can be very debilitating. For patients that do not respond to simple analgesics, NSAIDs, and those types of things, serotonin agonists were developed based on the observation that serotonin levels decrease, whereas vasodilation and inflammation of blood vessels in the brain increase as the migraine symptoms worsen during an attack. So serotonin agonists allow for there to be more serotonin and kind of clamp down on the blood vessels and the inflammation so that that's not all going to that site in the brain and causing all of this pain and distress. So an example of that is sumatriptan. It's a very common migraine medication, and that can treat all of those symptoms by acting as a serotonin agonist. Opioids can also be effective. However, they're reserved for refractory migraines that do not respond to any other therapy because, again, we don't want to prescribe opioids frequently or as a first-line medication. Sedatives and hypnotics are medications used to promote sedation in smaller doses and promote sleep in larger doses, as we've already talked about. They should not be used for extended period of time. There's a typo there. So they should not be used for extended periods of time, greater than 10 days, except under close medical supervision because of the potential for psychological and physical dependence. Again, these also depress the rapid eye movement phase of sleep, and withdrawal after prolonged use can result in a severe rebound effect. So they're kind of lumping this in on the migraine slide, even though we already talked about it, because those classes can also be helpful for severe headaches and migraines. The major anti-migraine agents, so you have, as I discussed, the serotonin receptor agonists, such as sumatriptan. The side effects are malaise, fatigue, dizziness, and drowsiness, asthenia, which is a general feeling of weakness, tingling, paresthesia, so like a numb feeling, and flushing, where kind of there's like a blood rush, your face gets really warm, or the area gets really hot and flushed, and then various cardiac complications. Opioids, again, these are reserved for refractory migraines that do not respond to other options. It has the same side effects as we talked about earlier: the lower seizure threshold, sedation, confusion, hypertension, bradycardia, etc. The common side effects of major sedatives and hypnotics. Over on the left here, the first one is antihistamines. You may be scratching your head hearing antihistamines and thinking, well, that's what I take for allergies. And it is. Antihistamines are used for allergic reactions. But think about if you've ever had to take Benadryl, for example, how drowsy you feel after. So antihistamines are also sedatives, and we actually do use them to that effect when we need to in a patient who needs some additional sedative effect. And it actually is oftentimes also used in a migraine cocktail when we're mixing medications into fluids to help reduce somebody's migraine symptoms. Side effects of antihistamines are blurred vision, dizziness, hypotension, confusion, and decreased coordination. Barbiturates and benzodiazepine. So barbiturates, again, benzos is a shortened word for benzodiazepines. Think of Xanax, Ativan, Valium, those kind of medications that are prescribed typically for their mild sedative effect, especially used with anxiety or for some kind of procedure that you need to be calm or still for, such as a procedure on the eye. The side effects of these medications are daytime sedation, confusion, and headaches, increased risk of falls, dependence or withdrawal symptoms, sleepwalking, and engaging in complex tasks, meaning that you can sleepwalk and actually do full tasks, full activities, and you may not even remember them, which is a very scary thought. Melatonin receptors. Melatonin is not listed as a controlled substance, therefore the side effects are not prominent. The big thing I tell people, though, who are taking melatonin, you can get it over the counter. And oftentimes people think that because they're having trouble sleeping, they want to take something like melatonin to help them, or even they give it to their kids. And the thing is, anything that you make naturally in your body, if you're already low in that, and then you're giving your body a synthetic version, you're almost telling your body, okay, well, I'm going to give that to you, so you don't need to make it. You actually end up lowering your levels further, which is a fear for using something long-term. So I always say, do some research, try to see ways that you can increase those levels naturally, because you don't want to give your body constantly something external, exogenous, and tell your body, no, I'm good. Like, you don't need to make more because you're already probably low in that thing. So there are lots of activities that can boost your sleep hormones and your sleep-wake cycles, such as avoiding blue light right before bed, avoiding big meals right before bed, that kind of thing. And then the last category here, orexin antagonists. Orexin is a neuropeptide that is part of the sleep-wake cycle. So the antagonists can act against that to help increase restfulness and decrease that wake cycle. The side effects are somnolence or fatigue, sleep paralysis, nightmares or abnormal dreams, and hypnagogic hallucination. So it's pretty intense pathways that this is acting on. These are going to be prescribed very carefully. Some examples of these are suvorexant, lemborexant, and daridorexant. So that rexant is kind of the common word in those. Those are Belsomra, Dayvigo, and Quvivic. If you've ever heard of any of those medications, they are not as commonly used. I don't see these as frequently. And then one other medication does not fall under orexin receptor antagonist, but Ambien is one that you may have heard of. That is a sedative hypnotic non-benzodiazepine. But Ambien has a lot of side effects as well, and it seems to kind of be going out of favor as a regularly prescribed medication. Knowledge check. Which major sedative has a potential side effect of sleepwalking? A. Melatonin receptor agonists. B. Orexin antagonists. C. Barbiturates. And D. Antihistamines. And the answer is C. Barbiturates. Patient education for analgesic, sedative, or hypnotic drugs. This is something that I will always advocate as strongly as I can for. Patients need to be educated in the benefits and risks, and they need to know what they're taking and why. So, what is the important education for analgesic, sedatives, and hypnotics? The potential for physical and psychological dependence and tolerance when we talk about our opioids, sedatives, and hypnotics. Not going to be the same for your non-opioid analgesics and adjuvant, but our opioid analgesics, sedatives, and hypnotics can cause physical and psychological dependence and tolerance. Take those three types, opioids, sedatives, and hypnotics. Again, I'm kind of not including the non-opioids and the analgesics. Take these only in limited doses for short periods of time, except to relieve pain in terminal illness. If you have a patient who is on hospice, who is terminally ill, we are going to give them pretty much whatever they want, y'all. You know, it is painful to die from cancer. It is painful to die from some of these conditions that are chronic. If they are actively dying, patients' family members especially, will sometimes still say, well, I don't want them to be reliant on it. Well, it doesn't matter because they're dying. And it's hard for people to wrap their heads around, but we will usually, if someone's actively dying in the hospital, we will put them on a morphine drip. We will give them as much medication as needed. And that's not because we're trying to hasten their death. It's because we're trying to make them as comfortable as possible. Caution with interactions. Do not take any medications that potentiate central nervous system depression except under close medical supervision. So these shouldn't be taken without medical supervision. There are serious potential side effects with prolonged use or overdose of opioids, sedatives, and hypnotics. A lot of times now, when they prescribe an opioid to somebody, they are also giving a Narcan as a prescription because you may accidentally take too much, or someone you love may get into your meds. Narcan is sprayed up the nostril and can reverse the binding of the opioid to the receptor. Tolerance with prolonged use, so increasingly large doses required to achieve the same effect can lead to more side effects. The potential for overdose of sedatives or hypnotics, and paradoxical reactions with older adults. Sometimes when we give medications that are in these categories, I think specifically of Ativan as one that I've seen. To older adults, it's a paradoxical reaction. So you're trying to sedate them. It actually makes them more amped up. So that's always a potential we want to be aware of. Withdrawal after prolonged use of sedatives and hypnotics can possibly lead to rebound effects, including nightmares, hallucinations, or insomnia. Mental alertness and physical coordination can be impaired, which could cause accidents or falls. Caution regarding over-the-counter analgesics and sleep aid combinations, and checking ingredients on the label to be aware of possible side effects with those containing aspirin. So some medications contain aspirin, which again can lead to kind of a thinner blood, can lead to bleeding. So you want to make sure if you're taking any blood thinners that you're not taking anything with aspirin. And sometimes it's kind of hidden in the medication. even things like Dayquil, for example. That's not in these categories, but just an example, Dayquil has Tylenol in it. People don't realize that. And so you don't want to take massive amounts of that and then combine it with Tylenol. So you should always be checking what your medication is combined with. Do not discontinue opioid analgesics, sedatives, or hypnotics abruptly. Can cause withdrawal and can cause serious side effects. And then make sure that these medications are properly stored and disposed. We don't want to put them in a place where somebody could get into them that shouldn't, such as a child, or a confused elderly person. And we do not want to dispose of them in a place that they can leak into the water system. I think back in the day they used to just say, well, flush your meds down the toilet. Well, no, we don't want these medications in the water system. We want to make sure they are disposed of properly and in a place where people cannot get to them. In the hospital, there is a secure bin that no one can open. So it has a little hole on top and, not no one, the pharmacy can open it and empty it, but that ensures that people aren't going to reach in and try to take any discarded medication. Knowledge check. Which is not included in important patient education for individuals taking sedatives or hypnotics? A, potential for psychological dependency. B, may discontinue at any time. C, mental alertness impairment. D, physical coordination impairment. And the answer is B, may discontinue at any time. We talked about side effects. Now we're going to talk about cautions and contraindications. For your opioid analgesics, contraindications or cautions, if somebody has a head injury, we typically will not give them opioids. And this is hard because I have had patients with major lacerations on their face or major head pain. Until I know that their head CT, their scans look okay, the patient's not at risk for suddenly changing their mental alertness due to the head injury itself, I don't want to give them anything like an opioid that could mask their symptoms of a real head trauma, a real damage to the brain. And so we won't give those typically if patients had a head injury. Cardiac disease or hypotension, because opioids can worsen both of those. Central nervous system depression. So if they already have a medication that's a depressant on the central nervous system, we don't want to further slow the heart rate, the blood pressure, or the respiratory drive. GI, hepatic, renal, and thyroid diseases. So certain diseases, depending on the medication, that impacts the ability for them to be processed properly by the body. And then chronic obstructive pulmonary disease and asthma, because both of these can lead to issues with breathing. And so we have to be very careful with an opioid that could suppress the respiratory drive even further. For your non-opioid analgesics, someone with GI symptoms, because it can make them worse. Pregnancy and lactation, because we don't want to do any blood thinning with a patient who is pregnant or breastfeeding. Asthma. Treatment of pain with NSAIDs after heart surgery. Hypersensitivity to acetaminophen. Sensitivity to local anesthetics, or non-intact skin. Non-intact skin is talking about if you're putting like a patch or something in a local area. We don't want to put something on top of non-intact skin or broken skin. For adjuvant analgesics, we talked about the SNRIs and the serotonergic medications, and these may result in serotonin syndrome, which is when high levels of serotonin build up in the body. Serotonin is needed for nerve cells and the brain to function. And so if you have a buildup of this in the body, it can cause agitation, restlessness, insomnia, rapid heart rate, all sorts of things. It's an emergency if this occurs. So this is something to be aware of. Caution may be used with anticonvulsants if this patient has a history of allergies, hepatitis, cardiac disease, or renal disease. Hypersensitivity during pregnancy. So some people can have hypersensitivity reactions to some of these adjuvants. Abrupt discontinuation is not indicated. It's not recommended. And then certain psychiatric conditions depending on what medication we are using as the adjuvant. And then for anti-migraine agents, patients with cerebrovascular or cardiovascular disease, we have to use caution with. Uncontrolled hypertension, because it's going to clamp down those blood vessels, which can actually increase the blood pressure. Peripheral vascular disease and hepatic or renal disease. Again, by clamping down the blood vessels, we reduce blood flow to that area. So in peripheral vascular disease, they're already getting poor blood flow to their periphery. So we don't want to make that worse. And hepatic and renal disease, we also don't want to reduce blood flow to the liver or kidneys. Pregnancy and lactation, we want the blood flow to still be occurring to the fetus, and then also when there's breast milk being produced, and we don't want it to pass through the breast milk to the baby. Children, and then older adults who are more likely to have decreased hepatic function and more pronounced blood pressure increases are also are at risk for coronary artery disease. That's also something we want to use caution with. And then for your sedatives and hypnotics, the cautions and contraindications include severe renal impairment, abrupt discontinuation. So again, these are cautions and contraindications. So these are things we need to be careful about, or that we contraindicated in people with these conditions, meaning not indicated. Older adults, we need to use caution. Patients who are debilitated, meaning they can't care for themselves or move about readily. Addiction-prone patients. Depressed and mentally unstable patients, because these are medications that can be overdosed on easily. Individuals who have suicidal ideation or behavior. Pregnancy and lactation. Children, chronic obstructive pulmonary disease, and sleep apnea for the same reasons as your opioids. We don't want to depress that respiratory drive further. Knowledge check. Which is not a caution or contraindication for an opioid analgesic? A, head injury. B, asthma. C, chronic obstructive pulmonary disease. D, renal impairment. The answer is D, renal impairment. These are typically not processed by the kidneys, and they also are not causing clamped down blood vessels, which is the big concern when we're talking about renal impairment. So renal impairment is not a caution or contraindication specifically for opioid analgesics. Self-assessment, remember this is at the end of the chapter to kind of refresh and make sure that you have a baseline understanding. 1, what is the difference between sedative and hypnotic medications? 2, can you list the side effects of anti-migraine medications? And 3, what are the side effects of opioid analgesic medications? Specifically for number 1, go do a little bit of a deeper dive in your text, because this PowerPoint is more of an overview. But as always, your text is going to have details that will kind of help you distinguish further when it comes to these questions. Thank you for listening. This has been Chapter 19 of Essentials of Pharmacology for Health Professions, 9th edition.